teaching and examination preparation, as well as for ophthalmologists, a refresher course in this COVID period. So, talking about diabetic retinopathy, I have no financial or proprietary interest in any of the equipment which I would be showing in this, and so I just want to show pictures and discuss about diabetic retinopathy, which is a major disease, major blinding disorder, a non-infectious blinding disorder which is there in the country. And so diabetes is a very vicious disease, and sometimes without realizing you lose vision because you never got your retina checked up, and you can get a C-fan like neovascularization as in seen in this patient. And other patient who presented to us, she was a 47-year-old female, and she was uncontrolled diabetic. She first came to us with the complaints of her uncontrolled diabetes. Age A1C was 17, and when we had a look at the dilated fundus pupil examination, the pupil was dilated, so we had a look at the fundus. We got her Optos 200-degree map, opto map picture showed very severe, heavy or severe fibrovascular proliferation extending, covering the disc and going to the periphery, as well as bleeding on the preretinal pre-halyard or subhalyard bleed, as well as the vessels you can see are very narrowed. So this kind of a patient has a very poor prognosis because the vessels are very attenuated and narrow, the function of the retina is affected, and the extent of fibrovascular proliferation would not be possible for one to do this kind of surgery and end up with some vision. Because most important is to get vision, not just to do the surgery. So the National Diabetic Retinopathy Survey was done with the RP Center associating with the National Control of National Program for Control of Blindness and Ministry of Health and Family Welfare. This was 1590, and it showed some interesting findings that the DR prevalence among diabetics was quite high. It was 16.9. This is a RAB survey, so we don't know exactly. Maybe it's more because RAB surveys are selected districts or selected population which the survey is done in the older age group, more than 50 years. And sometimes a dilated fundus examination until you have experienced examiners, you may miss DR changes. So even then, 16.9 is an extremely high percentage in a semi-rural urban population. And so why should a diabetic retinopathy occur if you got diabetes? And why it happens is because there's inflammation, subclinical inflammation, just like AMD. There is some kind of inflammation set up which causes microvascular damage. Diabetes already is causing hyperglycemia, which is leading to pericyte cell loss. So all that is leading to a metabolic response. There's going to be increased hyperglycemia, and with the pericyte loss, there'll be breakdown of the inner blood retinal barrier and exudation of plasma, lipoproteinous material, as well as outpouchings like aneurysms. Ischemia comes in because the RBCs become rigid, and there's a hyalization of the inner walls of the past positive material is accumulated in the capillaries. So it's basically a microangiopathy. So the capillaries get very narrowed, and the precapillary arterioles get blocked by RBCs. RBCs get rigid. It's called rouleau formation. And rigid RBCs with the damage to the capillary endothelial wall makes the platelets stick to that endothelial damaged cell wall, which also has a hyaline past positive material, plus the loss of pericyte, which is a supporting cell outside the capillary wall. So all these are multifactorial histopathological changes occurring at the same time, depicted in this flow chart. And there is increased because of ischemia, because the precapillary arterioles, this is the arteriole, this is the venule, this is the capillary network that gets clogged here, as well as the capillary network itself shuts down. So all that leads to what you can say ischemia, and ischemia always is a harbinger to VEGF release, and VEGF release causes neovascularization over the retina, on the retina, into the vitreous, and on the disc and elsewhere. So plus because of the leakage, as I told you, the breakdown of the blood retinal barrier, there will be macular edema. And so we'll quickly go on further because I like to finish by 4:30. So risk factors for diabetic retinopathy are there. Duration of diabetes is very important. Poor control is very important. So it's very important to tell the patient to control his diabetes. Pregnancy, it may progress. I've had patients who've had to undergo laser during their trimesters of pregnancy. Though they were well lasered when they went in for their pregnancy, but they had to get in additional laser because we generally don't give anti-VEGFs. Hypertension, nephropathy go in hand often, so it's important that the patient's blood pressure is well controlled and his renal parameters are checked at intervals of 3 to 4 months, 6 months, RFT, KFT, and even his LFT, because he may be taking drugs like lipid-lowering agents which affect the liver. So obesity and hyperlipidemia are also very risk factors. The National Institute of Health, Emily Chu, showed that hyperlipidemia played a major role in hard exudates. Smoking, of course, is a risk factor for all medical diseases. So all these risk factors which I just mentioned are actually being shown in studies that they are published clinical evidence that they are risk factors, published data. So most of this work's been done in the US, so some in UK. So ECCT UK PDS Accord, recent Accord told us that the glycemic arm, that blood glucose is an important factor. UK PDS also told us blood pressure is very important. Accord again told us blood pressure is important, but probably not so important. And DCCT told us about duration of diabetes. Lipid, the Accord definitely told us that phenofibrates and statins can be given. Field study also. You can read up this Accord study, and DCCT is there for pregnancy. Nephropathy, the UK PDS told us, and the Wisconsin epidemiological study from the US, Wisconsin state, showed that nephropathy played a role in DR. Obesity also the Wester emphasized. So what are the signs for the junior semester, first year PGs, anywhere in the country if they're listening in? They can say non-proliferative, maculopathy, and proliferative. So main is non-proliferative, then maculopathy we take it as a separate subheading because the macular changes actually cause visual loss or visual drop early. You may have NPDR, PDR with 6/6, it's maculopathy. So until you bleed or the fibrovascular proliferation causes macular pull or tractional attachment, the vision may be 6/6 even. PDR, I've seen patients 6/6. So all these background changes can be, which you all know. Maculopathy, you get thickening, hard exudates, and which can be in the form of single or a clump of hard exudates or a circinate ring because of the abnormal aneurysms, microaneurysms, and some capillary which starts leaking. So all around that you can get a ring of hard exudates. So actually when you laser in the center. So if you do the flow, this thing, okay, so the staging of mild is very few microaneurysms, probably a single soft exudates come in, but this actually doesn't fit into mild NPDR, is usually just a few microaneurysms. And then you can get severe NPDR. Yeah, please. So severe NPDR, you get more hemorrhages and dot-on-dot hemorrhages, not so much of flame-shaped hemorrhages. If you get flame-shaped hemorrhages in the case of DR, that means you've got hypertension. So because flame-shaped hemorrhage is more of a sign of hypertension, because I said HTDR go hand in hand. So you got a severe NPDR, which is also background diabetic retinopathy. The 4-2-1 rule is very important. The 4 is the 4-quadrant hemorrhages or microaneurysms. So we've got 4 quadrants of microaneurysms. That's very, very significant. It's very significant. So see the FA picture. This is a wide field picture which has been cropped. So the 2 is basically the venous beading, and you've got venous beading somewhere, and you can look for venous beading all around. You have to study the picture. You can't just take the printout and rush to for writing the diagnosis and the treatment. Because there's actually no point in just not seeing the image. And 1 is, of course, the very dangerous intraretinal microvascular abnormality. These are shunt vessels which tend to open up in ischemia. So you can get these shunt vessels opening up in ischemia, where a lot of ischemia is there. Wherever there are shutdown areas, capillary shutdown areas, there close by you may see some abnormal vessels over here. So these abnormal vessels are actually shunt vessels. So these shunt vessels actually should not be lasered when you're doing laser. Be very careful. You just don't blindly do laser. So never do laser without studying the angiogram. And once you study the angiogram, then put the laser spots, because blind blind scatter laser or blind PRP may damage the patient's blood flow as well as his functional potential to read, write, as well as to drive. All color vision, everything goes down. So it's very, very damaging if you do an improper laser without studying the angiogram. In fact, I feel that one should see the shunt areas and then decide not to touch them while doing laser. So you may spend extra time but it be worth it for the patient because he may become visually handicapped after laser if he wasn't before. So, and then of course you go into the PDR. The PDR, the very important thing is you should know what does HRC stand for. So ETDRS is defined very nicely. High risk characteristics in PDRs. NVD greater than 1/3 to 1/4. So NVD is readily growing onto the disc and is growing elsewhere also. So you got NVD 1/3 to 1/4. And NVD less than 1/3, that is less than 1/3 of a disc or to 1/4 display, but it's got hemorrhage with it. So here it's got more than 1/3 to 1/4, it's anyway HRC. But if you got less than 1/4, then if you got hemorrhage with it, or third option is you got a neovascularization elsewhere, not on the disc. So NVE and NVD are terminologies distinctive to DR. You can't say NVD, NVE in other retinopathies like in branch vein occlusion or CRV, or you can't say NVD, NVD. You can say disc neovascularization. The NVD, NVE is actually restricted to diabetic retinopathy. So if you got NVE with vitreous hemorrhage, that also becomes HRC. So you got some hemorrhage here, some hemorrhage here. Pre-retinal hemorrhages have started coming in. Patient's already been lasered. So he's got classical fibrovascular proliferation all around the arcade. So arcade gets affected very early. Imaging is very important, and FFA and OCT stays the gold standard, and Fluorescein has always been taken as a gold standard, but right now we have slightly moved away from doing invasive procedures, too much of invasive procedures, because the patient is also risk of allergic reaction, as well as we may not require it in the presence of OCTA. So it tells you about the baseline status, about the background RPE and all. Tells you about whether the edema is more diffuse or it's just focal edema. If it's focal edema and it's not in the center, you may do laser. If it's got diffuse edema, probably with center involving, then you may go in for a anti-VEGF. Grid laser is generally nowadays not considered to be the treatment of choice, because grid laser was advocated by the ETDRS, but grid laser causes a lot of functional damage to the macula. So nowadays focal laser is fine, but instead of grid, we rather do an anti-VEGF, bring it down to very minimal edema, and then when the edema is just like focal, then you probably put a few laser spots. Laser still stays a gold standard. So after that, scatter laser definitely stays, and no PDR treatment is complete, or a severe NPDR treatment is complete without laser. So only anti-VEGF has no role, because they are only finite treatment, and laser will give you infinite treatment. So sometimes they say that if the macula is ischemic, there is a school of thought that anti-VEGF may worsen the ischemia, but there's another school of thought which says that anti-VEGF may actually increase the macular flow. Very difficult to say. Probably give steroids then. Also, fluorescein is useful for this thing, fluorescein is useful for research tool. If you are doing some thesis project or some research project, you may have to do fluorescein as one part of that project to get it published. So traditional fundus cameras, which are there about 50 degrees, which are quite good. They give you a montage. You can take pictures of the periphery. 7 standard pictures which are given in the ETDRS plus pictures of the periphery, and get a good montage. So 7 standard fields gives you about a 75-degree field of view of fundus. So the Heidelberg non-contact wide field module, which is attachment lens on the Heidelberg, which is a machine, offers you 102 degree, which goes into wide field. Wide field is beyond 100. And ultra wide field is when it goes beyond 200 and 200 and above. That's what approximately is the definition. So the Optos gives you about 200 and 200 and above. If you move the patient's eye to the periphery, you may even get till 230 degrees to 40 degrees. 83, 84% of the retina you can see. They actually say 82% of the retina can be seen. So this is the Optos we use at RP Center, and this is the wide field single shot you get the picture. And so the fluorescein, when you inject dye, uh, you get straight away, or you take a fundus photograph, or you take a autofluorescent image. Also, you can do autofluorescent color photograph, fluorescein, ICG. So suppose you want to do some PCV lesion or something, you may like to do ICG, or if you want to look for RAP or something, or a PEHCR lesion. The fluorescein can be done very nicely, and you can see this picture of a fluorescein on the white field cropped up. You can see the Optos showing beautiful changes of very advanced diabetic retinopathy with proliferation with HRC on the disc, elsewhere NV. And you see the sausaging of the vessels. This is venous beading, and this venous beading with loop formation. This is very, very highly characteristic of a ischemic retina. This is a classical shunt vessel. You see, these shunt vessels are edemas. So the patient does not have one edema, but he's got edemas all over. So he's actually gone into PDR. He must have had these edemas initially, and then as the disease progressed, he went into PDR. So this came on early in severe NPDR. Ischemia developed, and then from there, he finally went into new vessels, and now he's got very severe PDR. So he's gone through the stages. You don't jump into PDR immediately. You have to go through the phases. You don't have to go into, you may go into severe NPDR very quickly, but from severe NPDR only you'll go to PDR. You can't say that I'm going to have mild PDR and NPDR and then tell the patient and then you went into PDR. That's not possible. So the histopathology and the cellular level, the changes which occur go slowly and steadily as the blood sugar stays uncontrolled, and also other factors, the genetic factors. So the PDR develops, a patient develops vitreous hemorrhage. So you see, this is a fluorescein, wide field. But here we've telling you, I'm just introducing, which I will tell you a little bit further on in next 2-3 minutes, what is optical coherence tomography angiography. This is a 12 into 12 millimeter square image, single shot, taken to tell you what is the status. And here the picture is not so wide as the Optos, and so you are picking up new vessels here and there, but the changes here probably outweigh the changes in this OCTA. So here right now the fluorescein is scoring over the OCTA. It's a dye-less flow of blood vessels which are seen, so it's just the RBC flow. So the OCTA 12 into 12 is not enough. We need wider montages of the OCTA probably here, in this case, where the PDR is also not getting picked up, the frank huge vessels. And this is another color picture on the Opto map or the Optos, which is just showing the new vessels over here. But the intensity of the PDR and the amount of ischemia is probably only picked up by the FA so well. So the FA, as I'm telling you, still stays as a gold standard. It's an invasive procedure, but you don't need to do it again and again. Once in 4 months or 6 months may be enough. And serial follow-ups can be done with the OCTA and a color fundus picture, which are non-invasive. And you can do a serial OCT also. So the OCT shows you that the fovea is very good. So you see the fovea is very good. The patient may actually can come sometimes with a vision of 6.6, 6.9, 6.12. He's not even in a, as per NPCB, the NPCB people in the ministry will say, oh, very good patient. He's got no DR. So he's got very good vision. So vision is not the only criteria. So teleophthalmology plays no role in retina. So patient says, I've got very good vision, I've got few floaters. So what should you do? Give him gentle eye drops, or should we ask him to get his retina checkup if he's a diabetic? I'm a diabetic patient. I telecall RPC AIMS as the MS and the AIMS people are saying. So I'm not saying against them, but they're saying patient is diabetic. He wants a retina consultation. He wants a fundus. He wants a ophthalmic consultation because he has few floaters. Vision is very good, and my eyes get a little red, because it's summer. So I give him some gentle floaters. Ke liye you can take some Neonac eye drops. So pressure we can't check, fundus we can't see. So where are we? We have a picture like this, and finally, after 3 months, when he comes back to you, he will be classified by the National Program for Control of Blindness as less than 3/60. Your patient is blind, and probably diabetic retinopathy proceeds symmetrically. So it may be that the other eye is even worse than this, or he's already lost that eye due to surgery or some massive hemorrhage or NVG. You see so many NVG patients roaming around in India and Delhi itself. So what I'm just trying to say is that for according to me, teleophthalmology has a very limited role. Only in post-op patients who've already been operated probably will just want to check up without tension. If he's having pain, you can give him additional prophylactic anti-glaucoma medication. Because if his eye is red, then he can show you a picture of his eye which is red. If you do a video call, if you go to telephone call, it's worse. If you go to video call, it's still better because at least a red eye and he's got some pain. What should I do? I'll start thinking. Today morning, somebody called up. I said, okay, you got any cardiac disorder? No. Okay. Do you breathlessness? No. Do you had COVID? No. Okay, then you start Combigan eye drops. Combigan I'm already putting. So I said, add Travertin. And if you got pain, I'd rather start on Tele ophthalmology. I'll start Travertin and I'll say take some artificial tears. I'm not going to just stop at artificial tears if it's a retina patient. You see, pressure immediately shoots up in diabetics and due to various causes, one of which is because of NVG only, or because he's got, POAG is very highly associated with, we've seen patients with the 9.9 cupping or total cupping with PDR or NPDR. So glaucoma goes hand in hand also. Not only hypertension, but glaucoma also. So this is another patient here. What you see is the fundus optos shows you a lot of exudates with hemorrhages and more of a maculopathy. Unlike the previous one, where the macula is very healthy. And here the macula is very affected, but the periphery is very healthy. Periphery is extremely healthy. And probably a little bit of neovascularization coming. We didn't do his FA in this case. What we got is more of a macular edema. And in this case you had normal. So every patient responds differently. It's not that this patient comes from this colony, so he's in containment zone, and he comes from another colony, he's in non-containment zone. Nothing like this. There is no distinction on basis on caste, creed, religion here. There is one patient who responds with maculopathy and severe macular edema, where immediate anti-VEGF will be given and he may actually do well. Get his lipids done, get his lipids controlled, start him on according to the cord, start him on anti-lipid lowering agents or lipid lowering agents, he'll do better here. He may even not require a very severe scatter. If he's got mild NPTI, even mild scatter is enough. What he requires is VEGFs. And to reduce his exudates, steroid lipid lowering agents. And probably can't say maybe the prognosis is better here. A third kind is this another kind patient. Third patient comes from another zone of India, and so you see this huge front over here, literally flat. See these things we can't see on tele or video consultation. Either we provide them with a fundus camera and NCT at home, then it's of value. Otherwise, you don't know what's happening. This front is very dangerous because you see, the minute I do is FA, the entire retina is ischemic. And this is the worst of the three patients. I'll say this is the worst. Why? Because his whole retina is shut down. He's gone into a retinal infarction. A retinal infarction of a very bad kind, which the whole capillary is gone. It's got some vessels perfusing, but all the capillary and the medium-sized vessels are absent. And it's all over the retina. He's just got perfusion of the posterior pole. So he's likely going to a dead retina syndrome, and he's got little bit of perfusion. His macula, if you see only OCT, suppose OCT not too bad, but reduce FA and his OCTA. Here the OCTA gives you tremendous knowledge. So here the OCT actually tells you there's a total ischemia of the entire retina of the temporal side, of the nasal side, and there's a huge brush of new vessels. So what should you do for this patient? It's like this patient is, you can tell him the prognosis first, that you're not going to regain vision, or you won't be able to be benefited by any of the treatments we offer you. We can do a laser for you, scatter laser, but your vision will probably not improve. There is no other option, and control of sugar. Usually by this stage, we don't expect much vision for this patient. And his prognosis, to tell him very frankly, bluntly, if you want to tell him that this is a eye which is not going to be probably going to be living with ambulatory vision if by chance. Otherwise, he'll have to have an attendant with him all the time because his vision must be very drastically affected, and he's probably going to NVG definitely, despite all your efforts at laser, because the more laser you do, more it'll get worse. So this is the worst of the three, and it's difficult to say who's better, who's worse, but all three were bad. So the utility of ultra wide field imaging, which we showed you Optos, is that you can see the periphery, you can quantify the periphery, you can see how much periphery you have, treat according to that. We're going to targeted laser photocoagulation. Try and do. I would recommend to everybody that who does laser treatment to do targeted laser rather than doing blind PRP, and detect the new vessels as early as possible. So OCT angiography is the second thing which I'm going to tell you about. This is the kind of picture we get at RPC, which is a TopCon swept source OCT. We get this segmentation. So it's a dialysis angiography. The RBC's motion is seen. You all know that. Study the retinochoroidal optic disc segments. So it segments the retina into superficial retina, intermediate, and the deep retina, outer retina, and the chorocapillaries. So 4 zones are seen. Always 4 zones are seen: superficial retina, deep retina, outer retina, chorocapillaries. See each zone separately for important, because each area may show you different changes which may not be seen in one, may be seen in one of the thing. One of the deep retina may show, the plexus may show, but the superficial may not show, and the outer retina may not show. The OCT is given along with, and this is 2 lines in it. If you can see it on your laptops, probably you'll see it, that there are 2 lines which you can actually use as manual guides, manual lines, which can manual segmentation. This is automated segmentation of the retina into superficial, deep, outer retina, and chorocapillary. But you can do manual segmentation to pick up the lesion of your choice. Suppose you want to look for some elevated lesion over here. Suppose. So you could do the manual segmentation in such a way the superficial line is just above this and the deep line is just below this. So that lesion would come, if it's in the region of the choriocapillaries or the deep retina, it will come up over here. So for even this is very significant, if there is some finding over there. So we'll know this is some kind of either there's some deposit over there, but there's no flow of, there's low flow lesion, or there's absence of flow in this lesion, or there is an ischemia over there. There's some ischemia over there. So all those things can be seen. Ischemia can be seen. You can pick up low flow, high flow lesions like new vessels. You can pick up ischemic areas or infarcts, but you cannot pick up leakage. That is a big problem. You cannot pick up leakage at all. New vessels and all you can pick up. This is a pseudo color image. So you can do this OCTA over here of a diabetic, because we are doing diabetic retinopathy. Here, the advantage of fluorescein, this is the fluorescein, this is the OCTA. The OCTA tells you this is at the superficial or deep retinal level. It is showing you that the retinal vessels are all individual vessels, showing the new vessel front, the way how extensive it is. Here we can't actually study it the way you can study it here. So the front study or the vessel study is much better in a OCTA versus the fluorescein, where the actual dye leaks out and blurs the image in less than a minute. So that way you can study the vessels very well. So if you want to do the laser and then study it again, then you suppose you're so much interested in retina that you want to do that. Normally we are not so interested. We just like to see the picture quickly and decide what should we do. Injection, laser, go home. 3. Or what else to do? Is OCT is showing some loss of you have segmentation. You have the inner retina is segmented into different layers. The outer retina is segmented. So she has a featureless retina. There's no segmentation of the retina. The retina looks as if it's dying. There's no segmentation. So this is called drill. We'll tell you what that is. And there's some dots over here. Some of these dots are showing shadowing, and the others are not showing shadowing. The ones which are not showing shadowing are the ones which are hyper-reflective foci. And some you have cystic spaces which are showing some hyper-reflective border. The hyper-reflective border is everything is reflectivities. Hyper-reflective border with a hyper-reflective interior is basically outer retinal tubulation, which is for some kind of neurodegeneration. So if some company is saying, I'm going to give you anti-VEGF to reduce your ischemia, the fluid, it's not going to help in such cases. So you tell the prognosis to the patient that you got neurodegenerative changes. Your vision may be very poor. We may give you anti-VEGF, but it will partially help you. Rest we need to do. This is the same patients, same patients. So everything is matched. So this composite pictures which I've taken are from our own patients, not from the Google images, and these are of the same patient and of the same eye. So all is a right eye. This is right eye and the right eye OCT. So here you see the retina is very badly affected functionally, and it's anatomically also very badly affected. So this picture I'm just taking a little time, but probably I'll just quickly move through, and you can see the OCTA. So OCTA helps you to pick up new vessels, all the microvascular abnormalities, the non-perfusion shutdown areas. The avascular zone study can be done very well if the ischemia is there. Extraretinal neovascularization seen, but no edema can be seen. So it's got a role. So here you can see that pre-laser and post-laser, the amount of decrease of front on OCTA. This is the FA. So FA and OCTA shows you nearly about the same of the front, and post-laser also there is improvement. So here also you can see this, neovascularization which has suddenly disappeared after laser. So laser is something which is, for PDRIs, Protocol S is something which we will take with a pinch of salt, because laser may be also equally effective, and you can combine the two. So there is non-invasive, patient likes it because the risk of vomiting or nausea always remains, and somebody has to use. It's a lot of physical work because you have to fill in dye, you find the antecubital vein, patient's collar has to be, button has to be open, his neck has to be totally free of any tight clothing, and he has not to have eaten. There's too much of knowledge, things to tell the patient, which present era it's very difficult. I can understand. So you see, the advantages of OCT are not only the fact that it's easier to do it, but less of talk to the patient. You don't have to talk so much to the patient, because FA you need to talk a lot, and nowadays era nobody likes to talk. So we like to just do it, as it is. So this you can just click the picture, the patient won't know what's happening, and you can take the picture and study it. So also for CKD, because a lot of our patients have chronic kidney disease, the urea, the creatinine is elevated. So for contraindicated a hypertension patient or something, probably he's got no attendant also, you can do an OCT. Limitation doesn't tell you about leakage. Artifacts are there, projection motion artifacts, you can read about it. And motion is moving into the eye or the head, and projection is the superficial images get printed on or literally superimposed onto the deep layers, like the chorocapillaries. Superficial capillary plexus, superficial retinal plexus, that area gets superimposed onto the deep 4 images, what I told you. So the OCT biomarkers are very important. Drill I just told you, disorganization and totally featureless central 1 millimeter foveal avascular fovea, and this is associated with worse visual acuity. Hyperreflective foci I told you, ORT also I told you, outer retinal tubulation, and macular thickness is also a surrogate marker with VEGF levels. ELM, external limiting membrane, also you can study if you wish to. It's superficial to the ellipsoid zone, EZ. So EZ disruption, all those outer bands are equally important as biomarkers, RNFL thickening. So this is telling about the drill, and you got hard exudates and hyperreflective foci also there. These are hard exudates because they're showing up shadows. This is a hard exudate showing up shadows. So all these are mostly hard exudates. So some small tiny ones are having no shadowing, so that's probably a dot-like hyperreflective foci. So this is another patient with showing you hyperreflective borders. So this is a ORT with some serious detachment, and the fovea is showing loss of segmentation, so drill, and some epiretinal membrane has developed, and the retina has gone into irregularity. The superficial retina is very badly, the dip is lost. So you can see the RP is kind of the subretinal fluids. The RP is there, but there's subretinal fluid over here. So the patient has some changes, and you can see another patient who's got a ORT very classical of the small OCT.
The hepatoprotective foci are basically aggregates of microglial cells in the DME eyes. They're thought to represent inflammatory cells, and it's an inflammatory biomarker. If you give anti-VEGF and steroid, they actually may decrease in number. Diabetic macular edema is the next thing. It's got a prevalence, and so you should know the center. Now we follow the not the classification which was 500 microns away and hard rates of thickening, or more than 1500 microns away. One part of which is within 1500 microns. That was the ETDRS definition. Now we follow the center non-center. This is drcr.net classification. Center involving, non-center involving. This is edema away from the center. Fovea is intact. So here we may avoid giving an anti-VEGF because center involving, you give them anti-VEGF. So all these DME factors are there for people going into the exam. There's oxidative stress, PKC beta activation, and increased VEGF production and accumulation of sorbitol. You know that the pericyte, which is the supporting cell, there is a polyol pathway in which the glucose gets converted to sorbitol by the enzyme aldose reductase. So there was a era when aldose reductase inhibitors were used, but they were very hepatotoxic. So increase of sorbitol causes the loss of pericytes and breakdown of the blood-retinal barrier. All these cause increased apoproteinaceous material into the extracellular compartment leading to DME. So in going into the history, most of this work has been done in the US. So 2000s we came into with triamcinolone. In 2015, 14, 15 we came up with VEGFs. First was bevacizumab, then ranibizumab, then aflibercept, dex implant. Everything came in around 2050, very recent. So we just 4 or 5 years, 2 years since COVID and 3 years extra plus COVID, you had the anti-VEGF. So first treatment was a focal laser. Again, this can't be studied on Tele ophthalmology. So for us, for retina people, I'll throw Tele ophthalmology into the dustbin. And focal laser can be done here. So you see the circinate ring over here. So circinate ring, you do laser here. But because close to a disc, don't do too much laser. Just do a very little laser. Very gentle light burns. So grade 1, grade 2 Esperance burns. Esperance is graded burns into 4 grades. So you see this laser how you've done. Very gentle, hardly visible. So very gentle burn, patient also is not loses vision, does not lose vision. Feels better afterwards. And so the role of anti-VEGF very important, but don't give too much stress into anti-VEGF because many talks may talk only of anti-VEGF. So what all I've talked before was imaging and laser and treatment. The bevacizumab, as I told you, ranibizumab, aflibercept, there are various companies making it. Rolosumab also came in, but it is only approved for neovascular AMD, not for DR. Vigabatrin is out. It was it's history now. And these are the various strengths and limitations. You can read this up from the book. It's a small molecule, and it's actually 48 kilodaltons. It's less antigenic, better retinal penetration. It doesn't cause any intravitreal reaction or occlusive retinal vasculitis. I find it very effective. Bevacizumab is also very effective. It is a larger molecule, 148 kilodaltons. It's got a longer half-life. So it is good for patients for pre-vitrectomy injections and stays in the retina or into the vitreous cavity compartment for long. It may have adverse effects because of its long stay in the vitreous cavity. So recent patients of stroke or MI may not require that. You should first get a clearance from the respective cardiologist because they all know anti-VEGF agents, and most of the cardiologists are well read, and they would do accordingly tell you that give it or not. So take their advice before you might land up into some medical legal issue, because those things are very relevant, though not in sitting inside RP center. VEGF trap eye is the aflibercept. It's got powerful VEGF binding and it's a potent inhibitor of placental growth factor. So it's a bi-monthly dosing, but somebody can get monthly, bi-monthly. Rolosumab is entered but it's not for, it's for wet AMD. It's got some side effects of 4% incidence of intravitreal reaction, about 1% incidence of occlusive retinal vasculitis. So you have to be very careful. So you can give various ways, monthly dosing or as and when required, or treat and extend. But you extend the treatment by 2 weeks. This was one protocol I'll tell you, which is protocol I. Now the protocol I was comparing laser versus all these are American protocols. They developed a diabetic retinopathy clinical research.net. Diabetic retinopathy clinical research.net. In that, they developed many protocols. One of the protocols was Protocol I. The Protocol I was, this is all studies relating to diabetic retinopathy. So they even studied the diurnal effect of these, on the diabetic macular edema. Anyway, so Protocol I is very important for you. Protocol I tells you about laser versus ranibizumab, a laser within 1 week of giving the anti-VEGF interval. Third was anti-VEGF, followed by deferred laser at six months. And fourth was triamcinolone with prompt laser. And so they found that the ETDRS visual acuity gain, because all these protocols and studies usually require the ETDRS visual acuity chart. We also have it here. So 18-letter gain percentage of patients with more than 18 patients who had more than 15-letter gain, 29, 28, and 22. So you see the ranibizumab did quite well. And finally, at 5 years follow-up, this was a study done by Michael Ellman from Baltimore, Maryland. And this man was very much into academics and reading, and he deferred. They did a 5-year follow-up also. The 5-year follow-up, he showed that deferral of laser actually improved the visual acuity best. So this he said at 5 years. This is a 2-year study. This is a 2-year data. So at 5 years, the data showed the best results came in the deferred laser group. That you give the anti-VEGF every month and do the laser only after 6 weeks, maybe 3 loading doses, and then probably as and when required. But 6 months later, that means 24 weeks is 6 months later, you give the first laser. So they said after 6 months, initially treat with loading dose and some additional laser, additional anti-VEGFs, but don't do laser till 6 weeks initially when a patient comes with DME. These are all DME protocols. So then was Protocol T comparing DME treatment with aflibercept, ranibizumab, and bevacizumab. Even now today, these 3 are the most accepted. You want to give brolucizumab, you can do it at your own risk. I will not. So overall improvement of aflibercept showed 13-letter gain. Okay, ranibizumab plus 11.2-letter gain and ETDRS gain, and bevacizumab was the least, but also 9.7-letter gain. So all 3 showed letter gains, and the outcome showed vision from baseline to 1 year. All 3 drugs at 1 year improved. Improved in vision. Improvement was vision at the end of 1 year in all 3. The only thing was aflibercept and ranibizumab were more. If the initial visual acuity was worse, 6.9 to 6.12, 6.9 to 6.12, then the letter gain was more with ranibizumab and aflibercept, but a little less with bevacizumab, but equally comparable nearly. Little bit of statistical, non-statistically significant. But if the initial vision is 6.18 or worse, this is 6.9 to 6.12, this is 6.18 or worse. If the visual acuity is worse with DME, then the maximum letter gain was with Eylea, then was lesser 14.2 letters with ranibizumab, and the minimum was with bevacizumab or Avastin. So what they said was the treatment burden was equal with all 3 agents, 15 to 16 injections through 2 years, 9 to 10 in the first year. That means 3 loading plus additional 6-7 injections were given. Second year, you just needed 5 or 6 injections. The patient was usually central macular edema was okay. So dry macula, OCT showed dry macula. So okay, fine. Follow up. Just 5-6 injections. Bevacizumab reduced about 40 to 50% less foveal macular thickness than ranibizumab. So it was not so effective. In eyes with initial visual acuity, this group, I'm talking about this group. The worse visual acuity, 6.18 or worse. Aflibercept led to greater mean visual acuity, 18.9 letters, improvement at 2 years. This is statistically significant, highly significant. So aflibercept did very well. All 3 are actually FDA approved. Bevacizumab is off-label FDA approved. So even for off-label approval, you have to go through FDA in the US. Here we have to go to DCGI, but DCGI has its own rules and regulations, which I don't wish to discuss, on how they clear a drug. It's best left unsaid. But the FDA is something which is, uncorruptible, and if they approve a drug, it's approved. If it's not approved, it's not approved. Best to leave it to FDA. We've got to get an FDA approval of a drug, only then we'll use it in RP center. So if all three are FDA approved, so we're using it. All three are available in RP center. We've got, and also a Geneva trial showed that CRVO, of course, but it is also improved for DME, the dexamethasone implant. So we're using all four in RP center. So this is the protocol S. So the total protocol I, protocol T, this is protocol S. Also from the diabetic retinopathy clinical research, this is the 50 hospitals in the US all collated their data, and they found that intravitreal ranibizumab was non-inferior to PRP at 2 years in PDRIs. This was mostly studies in which Neil Bressler and his wife Susan Bressler were the lead investigators. They compared laser to ranibizumab. Very kind of non-comparative. You can't compare laser treatment to an anti-VEGF treatment. You can compare one anti-VEGF to another anti-VEGF. You can compare laser to, because PRP is something totally different. However, anyway, so they thought we'll do that also. So the outcome 2A showed that ranibizumab was very effective, non-inferior to PRP, with visual gains of 2.28 and +2 letter than the ranibizumab PRP. Additional benefit of ranibizumab, Bressler said, was less visual field loss, and also that lower rates of vitrectomy, less vitreous hemorrhage. So, but there's one thing: patient has to come back for follow-up. In ranibizumab group of these two patients, if one patient getting an intravitreal ranibizumab versus PRP, I'll see happy if I'm in the PRP group, because even if I don't return for follow-up, I still got my laser inside my retina, on my retina. Well, if I don't get the anti-VEGF after 1 month because COVID came in, or I had fever, non-COVID fever or COVID fever, or something happened in the family, somebody was admitted, and I couldn't go back to the doctor because the doctor was not available, he was down with COVID. So then your anti-VEGF regimen goes for a 6, and you'll go in for vitreous hemorrhage, you'll go to TRD, and you'll lose your eye. So intravitreal ranibizumab, the biggest disadvantage of this protocol S is you have to maintain a follow-up with the patient, the doctor, who gives you the injection. And so each time you have to go back for the injection, there's a risk of end-off, there's the high risk of the doctor not being there, just like the lawyer, lawyer is not there or the judge is not there. Same way is with protocol S. So what is done is, what is recommended is to do a hybrid. That means you do laser definitely. And many articles are coming out, American publications are also coming out, that don't do anti-VEGF only for PDR. You have to do laser. And if you see here, this patient which we did, we gave anti-VEGF to suppress the new vessels which were not causing TRD. And these new vessels which were not causing TRD tended to suppress out. Then less laser was required. But probably laser has to be done. So there is a catch in protocol S. And this is one more protocol I'll tell you. This is a last major protocol, about 7-8 minutes left. We're towards the end. So anti-VEGF versus anti-VEGF plus steroids. So we wanted to study combined steroids and anti-VEGF. Again, this is a relevant study, not like protocol S. So steroid and anti-VEGF, combine it versus only anti-VEGF. Does steroid help in addition? So initially what they did was, for 12 months, they took only anti-VEGF patients. So 12 weeks, 3 months, 3 months they gave anti-VEGF. Okay. And this is the 3 loading doses. At 12 weeks, they randomized the patient. One group went off into the sham group, only got anti-VEGFs. Okay. Till 6 months more. So 3 months run-in phase of anti-VEGFs, monthly dosing, and then randomization phase, 6 months, total 9-month study. The one which went off to the sham group got only anti-VEGF, no steroids. Here also you're getting it monthly. Okay. Monthly on to 6 more months. Okay. While the other group got no ranibizumab but got dex implant or dexamethasone, 700 micrograms, the way we give it in RP center. Same way, there's a cartridge, and you hold the cartridge, and there's a trigger from the side, and you press the trigger when you're inside the vitreous cavity, and there's a small pellet which is released. That pellet is biodegradable, and unlike the Illuvian implant. And so DEX implant is not given monthly because the steroid stays for a long time. Usually the clinical efficacy is 3 months. So after the first 3 months would mean 12 weeks. Okay, 4 weeks in 1 month. So the second DEX implant is at 12 weeks later. So then what happened? What happened? Interesting study. Comparable visual gain. So patients with ranibizumab did equally well compared to combination of DEX ranibizumab. But structurally of the macula, the less fluid was seen in the eye, which had a combination of steroid and ranibizumab versus only this thing ranibizumab only versus sham. So ranibizumab only was here, while the fluid was much less. The OCT central subfield thickness was much less in the combination group, but the vision was equally good. So more important is the vision. So recalcitrant DME, change the molecule, switch to steroids, control diabetes. Steroids usually when you start DME treatment don't give initially. They said that it's better to start with anti-VEGF because steroids have some side effects, especially in phakic eyes. Patients who, told you patients usually have POAG with diabetic retinopathy or macular edema. And so you may have more problems on your hand if your patient gets steroid responder, and you will have to give him a lot of anti-VEGF 4-5 drugs, and he'll give Diamox, and sometimes it gets very complicated because the patient can't come, and tele-ophthalmology will not be able to tell you about the tension of the patient. That is the biggest thing. If somewhere we can monitor the IOP of the patient at home, many problems will be solved. So this is a DEX very well in patients with anti-VEGFs have not done well. So artificial intelligence has a role to play. There's this algorithm, artificial intelligence algorithm, which can analyze the fundus with countless images you can feed in. So it was correctly diagnosed the DR actually just like 87.4 times, when a board certified ophthalmologist in the US did using his indirect ophthalmoscope did it only 30 to 73. What you should have used is 90D lens or a 78. And market is for primary care physicians or ophthalmologists who don't know much about retina. It may increase the workload actually, because it may pick up DR without your knowing it, because without your seeing it, because the picture shows it. With drawback if it does it will only look for DR. If you're doing an AI algorithm screening, it won't pick up hypertensive retinopathy or there's a vein occlusion with it, or there's a retinal tear with it. It won't pick that up. So if you're only doing AI, then you will do a clinical evaluation. So it's not that the AI alone will take you through the problem. You need to still do clinical evaluation. So nothing less than a medical practitioner or an ophthalmologist seeing the patient. So this is if you got very good vision, better than 6.9. Protocol T told you about worse than 6.9. So if you got very good vision, 6.6, please don't give injection, because they found that patients with very good vision, even if there is a clinically significant diabetic macular edema, did better with observation. Observe. So don't inject any patient with DME. If his vision is better than 6.9, 6.6 parts, 6.6, don't treat. Hang on, wait, call him back in 4 to 6 weeks if he's COVID period going on 2 months. Try gym, give him longer follow-ups. Diabetic retinopathy, I don't want to talk much about this because the anti-segment surgeons would get annoyed, and it's basically you have to do a very nice cataract. And if you got retinopathy with cataract, for heaven's sake, make sure the anti-VEGF is given before doing cataract surgery. Heaven's sake. And make sure the laser, if you can put it in the case of cataract, put in laser, do the anti-VEGF at least 3 months, and also about 10 to 15 days before the cataract phaco surgery or the flak surgery, get his anti-VEGF given as a prophylactic measure, because the anti-VEGF acts maximally around 2 weeks. 3 to 5 days is the period when it's the maximum, reduces the new vessels, but the action is the maximum around 2 weeks. So the edema will go down at 2 weeks. So 2 weeks from the date of the anti-VEGF injection, you can tell him schedule your phaco surgery with your phaco surgeon, or if you're doing it yourself, then you're a pan ophthalmologist, then you do it yourself. As I only do retina, so I naturally tell my colleague, which I'm very happy that he does a good job for me, and then I take him back to under my care. So sometimes you have dense cataract, like this patient came to us, but the other eye showed marked retinopathy with edema. So if you have a dense cataract like this, I wouldn't say give a blind anti-VEGF, but after the cataract phaco, probably on the table itself you can give an anti-VEGF. So it's this is a last stage, and this is basically that you need to know that vitrectomy is not child's play. And if you got diabetic vitrectomy, you better take note of all the findings, get a good USG done, get a good OCT done if the media permits, and study that before the surgery. I mean, don't delve into surgery without the proper equipment also. You must have a chandelier light. You must have facility for bimanual surgery. You must have a very good endodiathermy and a good vitrectomy machine, which has a reasonably efficient cut rate and high cut rate, because you're going to work near the retina. If you don't have a reasonably high cut rate, you may end up creating more breaks than doing good to the patient. So you can do whatever 2D or 3D surgery, it doesn't make a difference. So this is a kind of a retrohilar bleed with it's got traction at the macula. So you've got to do a combined vector scanning, A and B both. Study the ultrasound very carefully. This is a surgery which we're just showing, and I'm just reached the end of the. So you had last 1 minute left, close to 4:30 as per the protocol. We got to do a 3:30 to 4:30 lecture. Agam sitting right here with me, and I'm not going to annoy Agam or anybody else that I'll go cross 4:32. He's given me 2 more minutes. He's signaled that I can take 2 more minutes. So what I'm doing is I'm trying to do a Gary Abrahams on block dissection. Gary Abrahams was a very leading vitreous surgeon, diabetic retinopathy vitreous in Wills Eye Hospital, Philadelphia. And he advocated in the late 90s, early 2000s, this on block dissection. And I find it extremely useful. And the posterior hyaloid can be lifted off as a single sheet, and then you can get the whole retina in view. Once the hyaloid is off, you bring down the IOP to 10, bleeders are shut off, and you laser under air, and don't laser close to the macula, and then the patient does well. So this is the patient, and because he had a TRD, we had put in some oil. But nowadays, of course, you're trying to put in less oil. And this is the last video, the second and the last video. Of course, we have many videos for DR. I have many videos to show you, but I will never be able to show you, and nor do I intend to show you, because this is just a little bit of what vitrectomy is, that you got to plan your surgery. You got to have 27 gauge also, because I use 27 gauge quite a bit. So 27 gauge gives you the advantage that the port is narrow, and the narrow port tends to create less breaks, and then go closer to the macula, go closer to the retina. And the cutting rate is same 10,000, but if it's not 10,000, it's 4,000. But the 27 port is narrow, so you can do a more cleaner job. You can remove all the membranes. So here we try to peel off from the disc outwards on the nasal side. The nasal side had very taut retina. You see, so taut post-operatively, you can see the retinotomy here, which I created. So the macula was clean, luckily, but his nasal side was very, very taut. So what I did was, his macula was clean, there was a lot of traction. I removed the traction, and then I peeled off the ILM to make sure all these striations and everything go away, and no subsequent ERM forms again. I just peeled off. So I had to do it because many times I don't do the ILM peeling, because the ILM peeling by itself. So you see, this is a nasal, this temporal, which is very good. The nasal side was so severely taut and unsettlable. So I had to make a little bit of a relaxing retinotomy, put some laser over there. So this is the patient's octa. We do the octa even after vitrectomy, and you see there's still areas which need laser. So we fill in some more laser, a targeted laser based on this. So this is the last slide. Take-home messages. I think there's nothing much to tell you that which you already know. So even the lecture may have told you, self-explanatory, and wherever I've already told you that you have to control every diabetes, hypertension, lipids, accordion study, also the imaging. I told you about PDR, what is PDR. I told you about non-center involving, you can do laser. But center involving, if it's there, you can give anti-VEGFs. Add laser, steroids. Laser, of course, is very important. Steroids the second line. And white field has its role, but it can be done without it also, because you can do montage. And surgery, of course, the vitrectomy machine, which you can do basically bimanual surgery and all that. And so, in case you're interested, you can read this. Thank you very much. Thank you, Akam. And thank you, Itvis. I hope I kept your time. I'll say bye to all of you.
Sir, there are some questions, I think, in the chat box.
Abhijit, yes. If DME is persistent after vitrectomy, then Abhijit, in vitrectomized eyes, the pharmacokinetics changes. The VEGF doesn't stay long in the vitreous cavity, but the dose is the same. So you give anti-VEGFs first. And then probably if the anti-VEGFs don't work, steroids can be given later. Because it's got a BSS filled up or a ringer lactate or aqueous filled up cavity now, no gel. So you give the anti-VEGFs first. Otherwise, if you want to give steroids, you can give. But the steroids may flow around and may even succumb into the AC or something. I'd rather give anti-VEGFs first. Give Avascular or something, ranibizumab. If the DME persists. Also tell him to control his diabetes. And also check for the OCT A or FA to see if there is any peripheral ischemia causing the DME. But this often happens. And we give the anti-VEGF. But if it's an oil-filled eye, give half the dose. Fluid-filled eye, gas-filled eye, we never do. If after the fluid-filled eye, after the gas, full dose. Oil-filled eye, half dose. So if you're giving 0.05 milligrams, you give 0.025 milligrams of Avastin. So you have to cut the dose to half because oil is like a reservoir. You have to reduce the dose to half. Bhavika, yes, sir, coverage can recently approve faricimab. Faricimab is not clinically available yet. Let it be FDA approved. It's got a bimanual action. It's angiogenesis as well as anti-VEGF. So it's difficult to say. There'll have to be comparisons. I'm sure the drcr.net would have thought of this protocol now. Once faricimab is FDA approved, only once the drug is FDA approved will the drcr.net take it up. I'm sure faricimab may show promise, and the comparative trial would be done with aflibercept, probably brolucizumab. I don't know what the Americans decide, but they're they are very fond of aflibercept, so they might try with aflibercept. You agree? You can't say faricimab is superior. You'll have to have a drcr.net trial, and this trial would have to go into years. You can't do 3 months only. So you have to go 6 months initial, then 1 year, then study the 2-year results. Michael Ellman did a 5-year follow-up. So same patients have to be followed up for 5 years. Will you have the energy and the effort to do 5 years trial on your same patients? It's very tough. But you have to do long-term trials, long-term studies. So we can't say if it's superior to aflibercept or not. It's very difficult. Thank you. Okay, Dr. Lamga.
Thank you, sir. Thank you so much, sir. Thank you, sir.
Thank you.
Very extensive lecture and very nicely covered everything, sir. Thank you, sir.
I don't want to say anything. Because if I say something, I may get hit the wrong way.